I want to welcome people to the healthcare scene after party. We're talking CommonWell and healthcare interoperability. This is the casual, take off your tie. Oh, I guess we don't have ties. This is health IT, right? Yeah, but this is the casual time to talk. We're here with Daniel Kane. He's the CEO and co-founder at Modernizing Medicine, and Scott Stuewe, director at Cerner Network. And for those wondering why we repeat, it's because this is for the YouTube version. But we did have one good question that wanted to dive a little deeper with you, Scott, on kind of the duocracy that you described. Shimcode, otherwise known as Steve, he said, how is it determined that functionality will be addressed deployed? It sounds like you said the member companies can kind of push it forward themselves by doing some of the legwork that's required. Is that what you meant by the duocracy?
Right. Yeah. So CommonWell, as a 501c6, it's a not-for-profit trade association. Practically everybody in the organization is a volunteer, and so really, pretty much the people who are volunteering are defining kind of direction. So by that, it's really factual to say that those who participate are getting their ideas moving forward. But that said, we do have a process around moving things through a funnel. So the board prioritizes ideas when they're at the business case level. Then use cases are proposed and approved through our use case committee, and then they move on to our technical organization. It's called the STIG, the Standards Technology Implementation Group. And after the actual change to the specification is made, the board actually approves the specification as well. So it is a committee structure. It doesn't move perhaps as fast as as one company would, but we'd like to think it works faster than other committee structures because we are all very focused on trying to make real world things happen quickly. So the duocracy is real.
Interesting. So you have to have some sort of governance, and at least having some sort of governance, at least there's a process where you can actually get something done, as opposed to the past where there was no governance. It was the Wild West with, I guess you have 50 member companies, so 50 companies all doing whatever they wanted. So I guess you take it either way. I'm interested to know more of the business model. I heard one EHR vendor, I can't remember which one, but I vaguely remember them saying something about CommonWell was their most exciting initiative from a revenue standpoint. Do you see that happening in the CommonWell community? Do you think there will, and I think some people would describe it almost as like a tax on interoperability, right? And the business model being, as we share records, we get paid, as a vendor, obviously as a provider. Do you think that's going to be the economics of the interoperability, or how do you think that will play out? Dan, you want to start?
Go ahead. Scott. No, go ahead.
I actually have never heard the story of a company thinking that by sharing records they're going to receive compensation for the information. That's a new one on me. I think that there truly is both a greater good aspect to CommonWell and making sure that information is where it needs to be, in the hands of the providers when they're about to make a decision on care, and making sure that information, it's not, again, this is not a central system. It's wherever the information may be, CommonWell helps get you to it, and then allows you to pull it into your EHR. And as Scott was saying, it really is about making sure that happens within the workflow of the normal provider-patient care. At least in Modernizing Medicine, where it is a normal sort of provider-patient environment. The workflows will be unique to whatever companies are trying to integrate it, but if it doesn't fit into their sort of stream, if it's something they have to go to, if it's a lookup, they've got to go over there and search for something and then read a bunch of information and then decide if they want to pull it in and then reconcile it with another whole worldview they have, and it's not going to work. But I think that the revenue opportunity sort of not what you said about being compensated for sharing data. I don't think that that's necessarily what I get excited about. But I do think that there's an opportunity for companies to access markets that they otherwise would have no way of accessing. So, take our partner here on the Blab, Cerner. We today, independent of CommonWell, have relationships with Cerner at hospitals where we have interoperability, but it's been very expensive for both of us to build and maintain. as CommonWell advances, we see opportunities, and this is not an instead of, this is in addition to. Modernizing Medicine has tools on mobile applications that Cerner maybe doesn't have an interest in developing, but the specialists that are at these institutions want to take advantage of. If we can have interoperability at the tool level through CommonWell at some point, where they can take advantage of a Modernizing Medicine widget or tool, and that information can then flow back into the Cerner system, then everybody wins. And so, again, the point here is to have things be, in addition to, where we're all gaining from each other, not instead of, where it's at the expense of one CommonWell member, someone else is going to thrive. I think here there's an opportunity for everybody to win.
And I did want to clarify something about, as a 501c6, we don't, it's illegal for us to set prices. So we don't, because we're careful. But what happened is, as those of us who began deploying made our decisions and made our announcements, so far, there's really kind of no economics around this that I'm aware of. I mean, no one has announced any model that requires any economics for the provider organization. So it's, I think we don't, in fact, in the CommonWell vision statement, the only thing that we can say is we do say that availability of this data should be at reasonable cost. So definition of reasonable so far is zero. So nobody can kind of complain about zero. But I guess the point is not so much that it's free, but that it's included, that it's what an EHR ought to be able to do, that an EHR ought to be able to connect to data that's outside. And I think that's kind of what people are thinking about this. There may be some level of economics in the future as, new value propositions or new use cases come up. But in general, I think we're dedicated to the notion that this should be a very low-cost model. We really see the value proposition mostly accruing to the patient. And as a consequence, it's pretty hard to get a lot of economics for it, because really the value proposition is mostly for the patient. And the providers are still incented to do a lot of work. I mean, hasn't shifted yet, right? If they do more stuff, they get more money. And until that changes really fundamentally, which is in the process of changing, then it won't really, interoperability still won't make sense for the enterprise. It's getting there, but it's still, it's still not quite there.
Interesting. There's so much challenge there, right? And we'll see how quickly it moves to value-based reimbursement to change providers' perspective on that topic. But what about the standards that are out there, with CommonWell? How far along are we? With creating standards or adopting the standards that exist? I think Dan's comment was really insightful when he said, we don't really have standards, we have protocols, which I think is a good way to describe my experience with the various standards is, that there's some protocols that get you close, but then you got to do all the extra work. Will CommonWell help to solve that? Or, what's the pathway there to really having true standards and not just protocols?
Well, I'll offer my thoughts first, and then Dan, feel free, of course. So I think that the standards are actually there to do an awful lot of what we need to try and accomplish. What's not there is that not everybody is able to do those standards in a verbose way. Frankly, what everybody's able to exchange today is what they were obligated to do under stage 2 meaningful use.
Yep.
And that's good as far as it goes, but there's a lot more data that is of interest to people. And the good news is, I think, meaningful use is adding some additional requirements to do some additional document types, which is useful. I also think that the marketplace, as people start relying on this data, they start, really trying to make these use cases do real work in their business models, then it's going to change what people are able to exchange. And I know that for us, we're going to be providing, this is Cerner speaking, not CommonWell, but we're going to be providing an awful lot of different kinds of structured documents next year. We can already provide unstructured documents for virtually any document that gets generated inside the EHR, but getting more and more of the data that happened, inside in a given encounter, I think that's going to be, a big part of what really moves people to more value in the next couple of years.
Interesting. So actually exchanging data and having that part of the workflow and the requirement of care is going to force us to have to figure out the standards. And that's a part of what you said, I think. Dan, did you have something to add?
No, I think Scott really said it, that there are plenty of standards out there. I think we just need to select the ones we want to embrace and then just agree that, okay, I've seen 100 different ways to sort of size up vitals as a simple example. But it doesn't matter which of the 100 ways we do it, as long as we all agree. And so, I don't think we need to reinvent, what, for example, CCDA already is accomplishing. I think we just need to, have a loose contract that within CommonWell, we're going to adopt these standards in this way. Unstructured data is kind of the easiest. It's all just binary. And so we can do that, but it's really the structured data. I think everyone is, understanding that that's the important thing, especially as we get to pop health, and being able to get a really good view of what's going on with the patient as a population level. It'll be fascinating to see, we have embraced kind of the lowest common denominator, which was what was required for meaningful use. And since all the EHRs, for the most part, were able to get to that bar, we all had a base level of CCDA that we could work with. But it's not a big leap forward from a technical perspective to start expanding on how we're going to use those types of standards or use the protocols to develop more of the standards to be able to exchange more and more information. I think that, again, the hard part was what CommonWell set out to solve, which is, are we going to be a federated search? Are we going to be a single repository? How do we get data rights? How do you move data? How do you discover patients? How do you discover providers? Those are what it solves. Now that we have an ability to deliver a payload, what gets delivered across it, I think will increase rapidly. So again, we're just in our infancy, but I'm excited for the future.
So Steve offered, he actually paraphrased down from the start of the session. He said, when you've seen the implementation of a specific standard, you've seen one implementation of that standard. I mean, we hear that over and over. But I think you're right. I often argued since the beginning, first thing we need to do is connect to the endpoints. We need to know who's who and which patient is which. If we don't figure that out, then it doesn't matter what we're sending, because we're sending it to the wrong person or we don't have the right identifier for the patient. Then the rest doesn't matter. But we can figure that out as we go. Seems like there's lots of progress that could be made there, though. So. All right. Any final thoughts before we close out the after party here? Scott, you want to start off? And what's most exciting? What's your final thoughts about what people should know about CommonWell and healthcare interoperability?
Well, I think the most important thing to understand about CommonWell is that since we're a group of competitors working together, we can solve the hard problems. We're sort of the only game in town with that in that regard. We're getting together to try and make this real world stuff happen. And that I think is, we're dedicated to doing it. We're all of the same mind, and we can assemble something, test it, prove it, advance it. We can do an awful lot more than you can do if you're a standard setting body, because we're organizations with clients that want to achieve this kind of interoperability. So I think that is. I think if we see success doing the kinds of things that we've described here today, then the personal stories that Daniel talks about, that people can reasonably expect that their record is available wherever they go, can actually be true. And I think the sad thing today is that the state of the art is, if you really want to have your record, you have to bring it with you. That's really sad. And it's sort of doesn't make any sense given the kinds of technologies that are available today. So I really do believe that we are at the tipping point here, where as CommonWell and the rest of the market kind of moves into this idea of patient really deserves to have their record available wherever they go, that they deserve to be able to get it when they're in their portal, that they deserve to have one portal and not 7, or at least if they've got 7, 7 can interoperate. these things are important to patients. And I'm very excited as I head into the part of my life where I'm more likely to be a patient than today, or I've been a patient hardly at all. I'm excited that maybe there'll be a time that my record will be available wherever I go.
That's great. And even if they do carry their own record, the doctor says, "What's that? I don't know how to pull that, fill out this form," right? If we could solve that, we'd all be happier. Dan, final thoughts about CommonWell?
Well, I want to applaud the larger vendors for coming together. They are competitors, and they took it upon themselves to do, what others hadn't for the last 50 years, and what the government either was unwilling or unable to do themselves. And so, when a vendor community takes it upon themselves to do something as big as CommonWell, it needs to be done, because these truly are in a lot of cases big time competitors from each other. So I applaud the initiative they took in bringing it. I also applaud them for including the larger community, for creating a duopoly where companies that have specific areas of expertise or specific desires can contribute and advance the entire state of the industry. So to me, this is really exciting. Modernizing Medicine is proud to be a consumer of it, but also a contributor to and a producer of the data for it. So we're excited. I do think we're just at the very beginning, the infancy of this movement. But as it gains momentum, it will gain more traction, more companies, more vendors, more patients demanding that their information is accessible. And we're going to see this thing continue to gain some serious momentum in the years to come.
Great. Well, as a patient, I hope you're super successful. I know as a blogger, I feel that, I have to be careful. I've heard the complaints that CommonWell is just a smokescreen to, say, oh, we are doing healthcare interoperability, and that it's not actually going to produce any results. So, we'll be doing our part to follow up and see how you guys progress with CommonWell, because obviously, it needs to be more than that. And, knowing Dan the way I do, I know he's interested in that. So I was really impressed that they joined the effort. And I know Cerner's made a huge investment in this as well. So I'll be watching it, and I think everyone will be, right? Because we're all going to be patients sooner or later if we're not already. So we want this to be successful personally as much as anyone. So I want to thank you guys, Daniel Kane, CEO and co-founder of Modernizing Medicine, and Scott Stuewe, director at Cerner Network. Thanks, guys.
Great. Thanks all.
Thank you.
Take care.